Okay, so today we will be going through the critical care respiratory system scenarios.
Okay, sir.
Okay, so this is your scenario. Kindly review it and then we will start.
Okay, sir. Okay, sir.
Okay, so calculate the surface area of the burn. For your ease, I have identified with blue color.
So chest is 9%, abdomen is 9%, both below is 18 plus 18, 36 plus 36. So 6 plus 54 plus 9, 63%.
Okay, so what will be your management plan for this patient?
Sir, I will. Sir, I will start with the ATL according to the ATLS protocol. I will start with the. I will first check according to the Wallace's rule of 9. I will first check the percentage of burns, which is 63%. Then, according to the ATLS protocols, I will check the airways first. If there is any airway burns, that says that there is soot in the so there is a presence of soot, and
Uh,
I will also check if there
Kindly
is any
speak a bit loud.
bit louder, sir.
Yes.
Okay, sir. And mm, if I'll check if there is any inhalational injury, airway burns, inhalational injury, then I will start oxygen for this patient. And next, I will check for breathing. In breathing, I will check if the patient's ventilation is adequate by looking for the chest rise. Because the patient has burns over his chest. And I will also check for any tracheal burns. Then, if the patient is having any full thickness or a scar, then we'll have to do a scarotomy. Then coming to circulation, I will insert two large bore IV cannulas and I will start with IV fluid resuscitation since the patient is an adult with more than 15% of burns, which is an indication for starting IV fluids. And I will also insert a Foley's catheter. Mm, and according to the Parkland's formula, uh, uh, 2 ml into 63 into what's the weight of the patient, sir? Hello?
Sorry,
What is the weight of the patient, sir?
I just considered it 70.
70. Okay, okay, sir. So 70 into 63 into 2, 140 into 63. So that is going to be the fluid resuscitation in milliliters. 50 ml will start in first 8 hours, followed by next 50% in the next 16 hours. And I will also start with the IV antibiotics, analgesia, and also will prevent hypothermia. And then I will give PPI to prevent ulcers. I will also provide enteral nutrition. I will start with a CV line for this central venous line. I will insert a central venous line for this, and
Okay. So you have
so,
performed
blood.
your initial resuscitation. So
Uh,
which type of fluid you will prefer? Would it be a crystalloid or a colloid?
sir, I will start with crystalloids. No colloids
Why?
is given, sir. Because if we give colloids, then it will expand the third space, lead to augmentation of the third space. So the proteins will shift from the intravascular compartment to the third space. So we should not give colloids.
So you have started the resuscitation. How will you
Yes, sir.
assess the adequacy of the fluid therapy that you have started for this patient?
Mm. I'll check for the urine output, and then I will check for the warmth, peripheral warmth of the patient, and we'll check for the temperature, the capillary refill time, and also the central venous will monitor the pressure, the central venous pressure. Yes.
Okay, so
So
what
I will
complications of burn you will suspect in this
uh,
patient?
since the patient is having burn in his chest, I will expect if the burn is circumferential, there could be an difficulty in expansion of the chest wall. In that case, we need to incise escarotomy we have to do. And since there can be scarring because high surface area of burns, there could be scarring also, and also associated infection. Then in coming to these are all local complications. When coming to systemic complications, the patient can go in for hypovolemia. Patient can go for shock, sepsis. Mm, there can be curling ulcers.
Okay.
There can be loss of proteins. There can be kidney injury. ARDS can occur.
Okay. So 4 days later, the patient developed tachypnea with a respiratory rate of 28 and oxygen saturation dropped to 88. So what will be your
Okay, sir.
diagnosis? Looking at the X-ray and keeping in mind the history that I have provided.
Mhm. The this is a case of ARDS because there is acute bilateral infiltrations seen in the lung field. Um, then um, the ARDS is an acute and diffuse inflammatory form of lung injury associated with the hypoxia and decreased lung compliance. Um,
Okay.
Decreased elasticity, decreased surfactants, which can lead to decreased lung compliance and deposition of the hyaline hyaline membrane, leading to uh, disruption in the gas exchange. Mm. Then the uh, PaO2 divided by FiO2 is less than 26.6. And normal pulmonary artery wedge pressure is less than 18 in this patient. It will also be altered.
So tell me about what is the pathophysiology of ARDS?
Um, the in ARDS, there can be two phases: the acute phase and recovery phase, reparative phase. In acute phase, there is ventilation perfusion mismatch. And there is a in the blood capillaries there is destruction of the endothelium. And there is a release of macrophages, and there is increased tumor necrosis factor, which leads to destruction of the type 1 pneumocytes. This leads to decreased elasticity and decreased surfactants, which leads to decreased expansion of the lung, that is, decreased compliance of the lung. And there is also deposition of the fibrin, and there is a development of a hyaline membrane, leading to impaired gaseous exchange and hypoxemia. In the reparative phase, sometimes it will get okay, or there will be fibroproliferation and organization of the lung tissue. If there is no resolution, then there will be deposition of the collagen and scarring of the lung.
Okay, so what will be
That's
your
it.
management for the ARDS?
Coming to management, I will first assess the patient according to the ATLS protocol. First, I will ask the name of the patient. If the patient can tell his name, then the airway is patent. And I will start, if or else I will call my anesthetist colleague to intubate the patient prophylactically. And I will next check for the breathing with the movement of the chest wall and movement of the chest wall. And I will start ventilation with high flow oxygen. Then I will set the PEEP to 5 to 15 centimeters of water, and the inspiration and expiration ratio of 2 is to 1. Then coming to circulation, I will insert two large IV bow cannulas, and start IV fluid for the patient. And I will also insert a Foley's catheter. I will start with antibiotics. Then I will avoid any nephrotoxic drugs for this patient. I will start with PPIs. I will also give low dose steroids. Then, if the patient is having a drop in the BP, we'll start with inotropic supports, preferably dobutamine. Mm, then
Yeah.
uh,
So
then
what else can cause pulmonary infiltrates on the chest X-ray, and how will you investigate for them?
what can cause pulmonary infiltrates in
Yeah.
the chest X-ray?
Yes, what could be the differentials for pulmonary infiltrates?
It could be a non-cardiogenic pulmonary edema. It could be a cardiogenic pulmonary edema, or it can also be a pneumonia,
Okay.
if not ARDS.
Yeah, so you did this session very well today.
Thank
So
you, sir.
your answers were pretty much accurate, but just try to revise them and try to concise them. Okay. You
Yeah, okay,
said the
sir.
answers right, but just try
Okay.
to take a bit less time, and that you can develop by continuous practice. Okay.
Okay, sir. The only point answering, sir.
Yes.
Because I think I was exceeding the time, but there'd be only 3 minutes for answering now, sir.
That's okay for the first try. Just try
Okay,
to, I was giving you enough time so that you can go through all the idea of that answer. So
okay,
that next time you will know that how you can comprehensively say it within less period of time.
okay, sir. Okay, sir.
Okay, so next we have this scenario. Kindly review it and then we will start. Okay, so can you please comment on this chest X-ray?
Sir, the chest X-ray, the lung is seen collapsed as there is blackout of the right thorax. Mm,
Okay,
and there is also a slight mediastinal shift.
yes. So can you briefly explain the system that is used for reading the chest X-ray?
Yes, sir. The system is A, B, C, D, E. For reading the chest X-ray, A is airway, B is bone, C is cardiac shadow, D is diaphragm, and E is pleural effusion.
Okay. So can you explain what are the different types of pneumothorax?
The types of pneumothorax are simple pneumothorax, tension pneumothorax, open and closed pneumothorax. Then that's all I need, sir.
So what is the difference between tension and simple pneumothorax?
In both in simple and tension pneumothorax, there will be decreased breath sounds. There will be decreased chest movements on the affected side, and there will be hyperresonance on percussion. And but in simple pneumothorax, there won't be any tracheal shift. But in tension pneumothorax, there will be tracheal shift and hypotension. And in simple pneumothorax does not need an emergency management. But the tension pneumothorax requires an emergency needle thoracostomy followed by a chest tube insertion.
Okay.
So,
So can you tell me about the boundaries of the safety triangle, which is used for the insertion of a chest tube?
the posterior border of the pectoralis major, the anterior border of the latissimus dorsi, and the line drawn along the nipple, which marks the lower border, and the apex of the triangle lies at the axilla.
Okay. What are the indications of central venous line insertion?
Um, if the patient requires a fluid resuscitation, if the patient to monitor the central venous pressure, if he requires any electrolyte-rich fluids like potassium-rich fluids, if there is any requirement for insertion of inotropes, cardiac pacing, and hemodialysis.
Okay, so what are the complications of central venous line insertion?
Complications, it can injure the lung, it can injure the internal carotid artery. It can lead to hematoma. Then it can also injure the thoracic duct, which can lead to chylothorax. These are all during the insertion. After insertion, the patient can also go into infection. There could be an embolus, or there can be the thrombosis of the vessel. Yes, sir.
Okay. What are the NICE guidelines for insertion of a CVP line?
Uh, Ultrasound guided procedure, and we have to take X-ray before and after the procedure. We have to take consent.
Okay, so what
Yes,
is the
sir.
technique for CVP line insertion?
We follow the Seldinger technique of insertion. Should I tell the procedure, sir? Entire
Uh,
procedure?
yes, explain the complete procedure.
So first, the patient should be placed in the Trendelenburg position. And then the center line is inserted. Then we have to locate the clavicle, then the two heads of the sternocleidomastoid, and in between the two heads of the sternocleidomastoid vessel. And the little bit lateral to it, we had to insert the needle towards the ipsilateral nipple at 30-degree coronal plane. Then we have to aspirate and check, how we do in the Seldinger technique. Then first we insert the cannula, then we insert the guide wire, then we remove the cannula, and through the guide wire we insert the sheath, and then remove the guide wire, and then flush all the tubes. That's it, sir. And connect the whatever fluid or electrolyte we want to give to the patient.
So explain the removal technique of CVP line removal.
For removal of the patient, we have to make the patient lie down with head down so that we can prevent air embolism. Then the central line is removed once there is no need for any IV fluid, no need for CVP monitoring, cardiac pacing, hemodialysis, or any requirement for inotropes. That's it, sir. Yeah.
Okay. So what are the different sites which are used for insertion of a CVP line?
The subclavian site, the femoral site, the in the neck in between the sternocleidomastoid.
Okay, what are the organisms which are responsible for causing infection?
Staph epidermidis.
Okay, and how can we prevent the line infection?
According to the NICE guidelines, we have to follow aseptic precautions.
Can you explain those precautions?
We have to clean the site with aseptic solution like chlorhexidine or povidone iodine solution, and we have to drape with in a sterile drape, and with the use of sterile gloves, we have to do the procedure.
Okay. So you did this session very well. Again, I would just advise you to continue with more and more practice so that you can take less time in saying all the things which you did. Okay.
Okay, sir. Okay. I
Now,
will
in the
practice it
indications and complications, one thing that I would like to add,
again. Okay, sir.
that for the indications, you can divide it. Okay.
Okay,
So
sir.
like
Okay.
you can give it for blood transfusion, for giving the patient fluids, for giving the patient food through TPN. And then
Okay.
it can be used for monitoring and certain procedures, like monitoring in a trauma patient, monitoring in a cardiac patient, hemodialysis, and for the cardiac pacing. So in this way, you will be very much clear that what things you are saying and something is missing on that, and you can add. Okay. So it is used for giving certain things, and it is used for proceduring and monitoring.
Procedures. Giving procedures and monitoring.
Yes.
Okay, sir.
And similarly for the complications, you can divide it into two parts. That is during the insertion and after the insertion. Yes. So during the insertion, you can damage the lung. That can cause pneumothorax. You can damage the internal carotid, resulting into hematoma and thoracic duct if on the left side, and bleeding and leakage can
Okay,
happen.
sir.
And then later on,
Okay, sir.
it can result into infection, thrombosis, and air embolism. I guess you forgot about the air embolism. That's very important.
Okay, sir.
And regarding the different sites, we have the internal, jugular, subclavian, and the femoral. Out of this, one addition thing that femoral is most notorious for getting the infection. So then they can like add this part and like what organism, then you will tell the organism and how can you prevent such infection from happening.
Okay, sir.
Okay. So next we have this scenario, kindly review it and then we will continue. Okay, so what will be your expected physical findings in this patient?
Expected physical findings are tachycardia, hypertension, then the tachypnea. Since the patient is post-op and receiving IV fluids, 7 liters and with normal saline 4 liters. There is a fluid overload and saturation is 54% in room air, I think. So the patient is desaturated and the urine output is 15 ml per hour. So the patient is having oliguria also.
Okay. So what will be your management plan for this patient?
Sir, I will start the patient with according to the sir, I will start the patient with elastics. So before that, I will insert the central venous line. So my urine output is already been monitored, and I will manage according to the CRISP protocol, sir. The ABCDE approach, and then first of all, I will stop all the IV fluids, and I will start the patient with oxygen, high flow oxygen. Then in the CVP line, I will start with the IV furosemide. Since the BP is 160 systolic, I can give a furosemide. I can also give a glycerol trinitrate, GTN. I will call the ITU to shift the patient to the ITU. I will also train the junior staff so that there is no incidences which happens like this again. And I will also report it to the incident reporting system. Initially, I will do some investigations. I will take ABG from the patient. I will do basic blood investigations. Then with a full blood count, urea and electrolytes, and lactate. And I will also do a chest X-ray and ECG. If needed, I will also give, apart from the high flow oxygen, I will also give the patient some ventilatory support, like CPAP is preferred in this patient.
So comment on this chest X-ray.
The chest X-ray shows bilateral basal lower lobe opacifications, which is suggestive of pulmonary edema. And there is also loss of the cardiophrenic angle. There is widening of the cardiac shadow, more than 50% of the anteroposterior diameter. Mm,
Okay.
yes.
Why this patient is at a higher risk of developing myocardial infarction?
Uh, the risk of developing cardiac infarction because of high BP, heart rate, then there is also a few fluid overload. Um, so, since this patient is having a fluid overload, there will be pumping, heart's efficiency in pumping will be affected. Mm, there won't be any effective, adequate preload. Cardiac output will be decreased since because of that. Then this will affect the blood supply to the heart, the coronary blood vessels, and the patient can go into MI.
Okay, so what is the minimal level of the urine output that should be present in a 70 kg healthy male?
0.5 ml per kg per hour.
Okay. So can you explain why this patient has developed oliguria?
Uh, the patient is a post-operative patient. Mm, So I think after surgery, there will be some stress response present, which can lead to the increased release of hormones such as glucocorticoids and mineralocorticoids, which will raise the blood pressure. The raised blood pressure is due to the preservation of the salt and water. Uh, Salt and water retention. Then that's all.
Okay. So can you tell me what are the fluids which are given to this patient?
There are 7 liters of fluids given with 4 liters of normal saline.
Okay. So can you tell me the amount of sodium in 0.9% normal saline and Hartmann solution?
In normal saline, 150 millimoles per liter. Then in Hartmann solution, 131 millimoles per liter.
Okay. So what measures you can use so that such event does not happen in the future?
Sir, I will report to the incident reporting system in the hospital. I will also train the junior staffs in resuscitating the patient post-operatively so that there won't be any problems like this in the future.
So in this scenario, when you're telling about the physical findings, just assume that you are looking at such a patient. Okay.
Okay, sir.
So first of all, on inspection, there will be shortness of breath, use of accessory muscles. You can identify any
Okay,
oxygen mask or any CVP line if it was already present, or tachypnea. Then
okay.
on auscultation, you can find bilateral crackles in the lung fields. There will be raised JVP, and very importantly, there will be pitting edema on the face and the legs.
Mhm.
And the
Yes.
patient can also present with confusion.
Okay.
Okay, so you have to keep these 2 or 3 things in mind. They are very important physical findings. And regarding the risk of MI, because there
So
is
we should not,
already, yes,
sorry. So we should not tell about physical findings. We should not tell about hypertension or tachycardia. Can we?
sorry, can you repeat that?
Sir, should we not tell about tachycardia and hypertension
Yes, you can
in
add that as well.
yeah.
No
Okay,
problem with
okay.
that because they're like already present. Na? They're
Yeah.
already given in your
In
notes.
the notes. Okay.
Yeah, so you have to tell
Apart
the
from that.
additional things. Yes. So
Okay, sir.
those are like the findings on the clinical examination.
Okay, sir. Okay.
So you have to focus on the inspection, palpation, and auscultation, and
Mm.
pitting edema, which you can view it.
Okay, sir.
And then regarding the risk of MI, because of the tachycardia, there will be a decrease in the diastolic time, and that will reduce the cardiac filling and eventually increase the load on the heart. And in addition to decreasing the preload, it will increase the risk of MI.
Decrease in the preload. Okay, sir.
And
Okay.
regarding
Because of tachycardia, there is a decrease in the preload.
yes,
Okay, sir. Sir, one more doubt, sir.
yes,
When because there is also tachycardia, but there is also fluid overload. So, but can so there is already fluid there. So the stroke volume can be normal, no, sir. Why is it not the stroke volume? Sorry, the preload. Since since the fluid is no, overload, that won't happen. Will that happen?
okay. So because of the tachycardia, the
Okay.
filling time is reduced.
Because of
Okay.
okay. Okay,
And
okay. So that is the reason why
no,
preload
no,
is
there is an
reduced.
additional thing, pitting edema.
Okay.
The fluid might be over. The patient is in fluid overload. There is adequate fluid, but it has gone into the other
Third
compartment.
space. Third
Yes.
space. Okay,
It is
sir.
not
Okay.
available for the heart to pump. So these
Okay.
things, when add up, they will increase the risk of MI or cardiac pathology.
Okay. Okay, sir.
Okay, so
Mm.
regarding the oliguria, you rightly said that the patient will be having a physiological response, which will be added
Stress
up
response. Yes.
into the surgical response as well, because the
Okay, sir.
trauma of the surgery or the stress of the surgery is also going to release the stress hormones, and all the stress hormones are built in such a way that they will reabsorb more and more water and electrolytes so that they can be conserved in the body.
Okay. Yes, sir. Concerned.
Okay, so any questions?
Sir, this is because I studied it recently. That is the reason why I'm remembering it. So will we be having any revision class so that because I think I will forget after some 4 or 5 days if I don't revise.
Sorry, what?
Sir, will there be any revision classes? Because I tend to forget these things after some 2 3 weeks. I will tend to forget all this. Now I remember it step by step, everything. But